Now let's talk about the endometrial carcinoma. Endometrial carcinoma is the most common malignant disease of the uterus, and it arises from the glandular component of the endometrium. And endometrial cancer is most common in women over the age of 45 years. And the etiology of endometrial cancer is the unopposed estrogen stimulation. And the high estrogenic state may be because of certain endogenous causes or the exogenous causes. The endogenous causes of the high estrogenic state include aromatization of the peripheral androgens, and high estrogen secretion may also occur from the estrogen producing tumors that are the granulosa cell tumor. The exogenous causes include hormone replacement therapy that contain estrogen only in the tamoxifen. Tamoxifen has a inhibitory effect on the breast, but they had a stimulatory effect on the endometrial tissue. Now let's talk about the types of the endometrial cancer. So the types of endometrial cancer include endometrioid, which is also known as adenocarcinoma, and it is the most common type of endometrial cancer. Second one is squamous cell carcinoma, adenosquamous carcinoma, clear cell carcinoma, and the papillary serous carcinoma. The endometrial cancer is also divided into type 1 cancer and the type 2 endometrial cancer. Type 1 cancer is estrogen dependent, and it arises from the endometrial hyperplasia, and it occurs in younger age, and it is low grade cancer. Therefore, it has a favorable prognosis, and it is associated with inactivation or inhibition of P10 gene mutation. And the most common type of type 1 endometrial cancer is endometrioid cancer or the adenocarcinoma, and the risk factors include the unopposed estrogen level. And the type 2 endometrial cancer is also known as estrogen independent carcinoma, and it arises from the endometrial hypertrophy, and it occurs in older age, and it is a high grade carcinoma. That is why it has a poor prognosis, and it is associated with mutation of the tumor suppressor gene, that is a p53 gene mutation, and it includes the serous cell and the clear cell carcinoma of the endometrium. And the risk factors for type 2 endometrial cancer are not well understood. Now let's talk about the risk factors for the endometrial cancer. So the high estrogenic state include obese women, nulliparous women, women having early menarche and the late menopause. There are functioning ovarian tumors that produces estrogen, and the women who use hormone replacement therapy that contain estrogen only, in the tamoxifen therapy. Similarly, pelvic irradiation and the family history, all of these contribute to the development of the endometrial cancer. Similarly, the endometrial cancer may be associated with a genetic syndrome, that is the Lynch syndrome, which is also known as hereditary non-polyposis colorectal cancer, and it is the most common genetic risk factor for endometrial cancer, and it is an autosomal dominant condition, and it is caused by the mutation in the DNA mismatch repair gene. Then it predisposes the patient to colorectal cancer, urothelial or transitional cancer, and the ovarian tumors, and similarly, it also causes endometrial cancer in around 40 to 60% of the women. And the risk of endometrial cancer is decreased in case of pregnancy, oral contraceptive pills, intrauterine devices, and hysterectomy. In hysterectomy, we remove the uterus, so there will be no chances of endometrial carcinoma. Next is the signs and symptoms of the endometrial carcinoma. So the most common symptom in postmenopausal women is postmenopausal bleed. In premenopausal women, there will be abnormal uterine bleeding occur. And the delay symptoms also include abdominal pain and distension due to the growth of the tumor, and there may be abnormal bowel movement occur, and urinary dysfunction occur in case of extension to the bladder. And the abnormal bowel movements are due to distension or the mass effect of the tumor on the rectum. And the differential diagnosis of endometrial carcinoma include atopic vaginitis, endometrial hyperplasia, endometrial polyp, and the cervical cancer. Next is the investigation done in case of the endometrial carcinoma. First one is the baseline investigations that include the complete blood count, urea and electrolytes, liver function test in case of metastasis to the liver, and we also do chest X-ray in case of metastasis to the lungs. And the specific investigations include transvaginal ultrasound, and these findings are suggestive if the endometrial thickness is more than 4 mm in a postmenopausal woman with a history of postmenopausal bleed. And MRI pelvis is the investigation of choice, and it is done for the staging of the endometrial carcinoma. And similarly, we also do endometrial biopsy, and we do the histological assessment of the endometrial tissue. Next is the staging of the endometrial carcinoma. So the PIGO staging is most important, and according to PIGO staging, the endometrial carcinoma is divided into four main stages. First is the stage 1. In stage 1, the cancer is confined to the uterine body. In stage 1A, there is less than 50% of the invasion occur, but in stage 1B, there is more than 50% of the invasion of the uterine body. In stage 2, the cancer invades the cervix, but there does not extend outside the uterus. In stage 3, the cancer extends outside the uterus. In stage 3A, there is involvement of the cirrhosis of the uterus. In stage 3B, the cancer invade the vagina or the perimetrium. And stage 3C, there is metastasis to the pelvic or the para-aortic lymph nodes. And stage 4, there is metastasis occur. So the metastasis may occur posteriorly into the bowel and anteriorly into the bladder. So the metastasis to the bowel and bladder is the stage 4A, and if there is distant metastasis to the lung, it corresponds to a stage 4B. So in stage 1, the cancer is confined to the uterine body. In stage 2, the cancer invade the cervix. In stage 3, the cancer extend outside the uterus. There may be involvement of cirrhosis in case of stage 3A. Stage 3B, there may be invasion of vagina and perimetrium. And stage 3C, there is metastasis occur to the lymph node. And stage 4, there is distant metastasis occur. Now let's talk about the management of the endometrial carcinoma. So surgery is the mainstay of treatment of the endometrial cancer, and surgery it consists of total abdominal hysterectomy along with the bilateral salpingo-oophorectomy. This surgery involves the removal of the uterus, both fallopian tubes, and the OI. And this surgery can be performed via the transabdominal route or the transvaginal route. And if there is cervix involvement occur in stage 2, we do modified vertical hysterectomy, in which we remove the uterus, both the fallopian tube and the OI, and it also involves the excision of the vaginal cuff along with the excision of the paracervical and the parametrial tissue. And the indication for the pelvic and para-aortic lymph node dissection include high-grade carcinoma, that is the grade 3 cancer, and the type 2 endometrial cancer. And for advanced cancer, we do debulking surgery. Next is the adjuvant treatment. Adjuvant means the treatment that is given after the surgery. So they include adjuvant radiotherapy and the adjuvant chemotherapy. Adjuvant radiotherapy, they reduces the chances of local recurrence, whereas the adjuvant chemotherapy is given in case of advanced or metastatic disease. Similarly, we also give the hormonal therapy that include the high dose of the intrauterine progesterone, and they are given as a palliative treatment. And similarly, we also give the high dose of intrauterine progesterone in case of low grade stage 1A tumor. But chemotherapy, the hormonal therapy have higher chances of relapse. So in stage 1 endometrial cancer, we do total abdominal hysterectomy along with the bilateral salpingo-oophorectomy. We also remove the adnexa because they may contain subclinical metastasis, and we obtain peritoneal cytology. And similarly, we also do omental biopsy to detect a spread to the omenta. And the cut section of the uterus should also be examined to assess the depth of the uterus involvement. And removal of lymph node is controversial in case of stage 1 disease, but they are done to know whether the lymph nodes are positive or not. Stage 2, where there is an involvement of the cervix. So if there is microscopic involvement of the cervix, we do total abdominal hysterectomy along with the bilateral salpingo-oophorectomy and post-op radiotherapy or adjuvant radiotherapy. If there is macroscopic involvement of the cervix, then we do modified radical hysterectomy along with bilateral salpingo-oophorectomy. Similarly, we also do bilateral pelvic and aortic lymph node dissection. In stage 3, we obtain CT of the pelvis and abdomen. If the disease is confined to the pelvis, we give radio to the patient, and if there is clinical spread to the adnexa adjacent structure, we do laparotomy. And stage 4 disease, where there is a distant metastasis occur, we give palliative treatment to the patient, and we can also do the debulking surgery. Next is the prognosis of the endometrial cancer. So the prognosis depends upon age of the patient, stage of the disease, and grade of the disease, and also the lymph node and the vascular involvement. So the prognosis decreases with the advancing age of the patient. If they are grade 3 tumors, if there is type 2 endometrial carcinoma, and there is deep involvement of the myometrium, and if there is lymphatic or the vascular spread occur. And the 5-year survival rate for stage 1 disease is 88%, stage 2 is 75%, and stage 3 is 55%, and stage 4 has only 16% of the 5-year survival rate. Now let's talk about the sarcomas of the uterus. So sarcomas are the tumors that arise from the myometrium, and they are malignant in nature, and they are mesenchymal in origin, means that they arise from the mesenchymal tissue. And the sarcomas account only for 5% of the uterine cancer. And the sarcomas are divided into three types. First one is the sarcomas, which is also known as leiomyosarcoma. Second one is mixed epithelial sarcomas that contain both carcinomatous and the sarcomatous components, so they are known as carcinosarcomas. And the third one is heterologous sarcomas, which is also known as the rhabdomyosarcoma. So first one is a leiomyosarcoma, which is also known as the sarcomas, and they are the malignant tumor of mesenchymal in origin, and they arises from the uterine smooth muscle, and they have high chances of recurrence, and they involve the malignant transformation of the fibroids. So the clinical presentation include a woman in between the age of 40 to 60 years having a rapidly growing mass along with increasing pain and irregular bleed, and there may be increase in the size of the tumor after menopause, while in case of fibroid, which decreases in size after menopause. So the leiomyosarcoma, they increases in size after menopause, and there may be hematogenous spread occur to the lungs and the brain. For diagnosis, initially we do the transvaginal ultrasound, which indicate a mass, and then we do MRI, which is the best imaging modality, but it cannot differentiate it from the fibroid. And MRI shows areas of necrosis within a fibroid in a patient having a rapidly increasing mass. Similarly, we also do the histopathological examination from the biopsy, which is the only definitive way of diagnosing and differentiating it from the fibroid. So, in criteria one, we have more than 10 mitosis and there is no nuclear atopia required. But in criteria 2, there are more than 5 mitosis along with the nuclear atopia required for the leiomyosarcoma diagnosis. And in the surgery, we do the total abdominal hysterectomy along with the bilateral salpingo-operectomy, and we also do the adjuvant therapy after the surgery, that include the adjuvant chemotherapy, adjuvant radiotherapy if there are more than 10 mitosis present on the biopsy. Second one is the mixed epithelial sarcomas. They are also known as the carcinosarcomas, and they are composed of two main components. They involve the glandular proliferation, that is the carcinomatous component, and they also include the mesenchymal proliferation, which is known as the sarcomatous element. And the sarcomatous element may be homologous, that is the tissue of the uterus that include endometrial, myometrial, or the stromal component, or they may be heterologous tissue, means that the tissue from outside of the uterus that may include the bone, cartilage, or the skeletal muscle. So in the carcinomatous component involve the glandular proliferation, whereas the sarcomatous element include either homologous tissue from the uterus or the heterologous tissue from outside the uterus. And the presentation include women that is post menopausal. There may be a history of previous pelvic radiation occur, and there may be a history of post menopausal bleed along with a fleshy mass protruding from the cervix, and there is a uterine enlargement also occur. And the treatment include surgery, which is a total abdominal hysterectomy along with a bilateral salpingo-operectomy along with post-op radiotherapy. And the 5-year survival rate is 73% if the tumor is confined to the uterus, and the chances of survival, 5-year survival, are 25% if the tumor extends outside the uterus. Third one is the rhabdomyosarcoma, which is also known as the heterologous sarcomas, and these tumors are composed of the heterologous elements, means that they include the tissues that are not present within the uterus, like they may include the skeletal muscle, bones, and the cartilage. And the rhabdomyosarcoma include two types. One is the adult type, and second one is the infantile type. The adult type present as a large fleshy mass which protrude from the uterus wall into the uterine cavity. So they present as a fleshy mass which protrudes into the uterine cavity, and it metastasizes via the bloodstream, and there are high chances of recurrence. And the infantile type is also known as the embryonal rhabdomyosarcoma, and they present with a blood stain and watery discharge, and the vagina is found to contain a grape-like masses that arise from the cervix, and it is spread locally and can cause death by penetration or contamination to the peritoneum, and they also spread towards the urinary tract and causes urinary tract obstruction, and they have high chances of recurrence and after the removal. And similarly, the distant metastasis is also common.